So the sleep studies, there you go. So there are some indications for the sleep studies. So the sleep studies indicated to diagnose sleep disorders, sleep apnea, obstructive and central sleep apnea, narcolepsy, periodic limb movement disorders, insomnia, night terrors, nocturnal panic attacks, sleepwalking, talking, and other sleep behavior disorders, as well as sleep paralysis and other types of parasomnias. But also is used to assess the effectiveness of the treatment and for research. The American Academy of Sleep Medicine has split in 4 groups the types of the devices available, according with the number of channels, according with the information those devices are providing. So the type 4 is the very old device used in the sleep services, is the pulse oximetry. You have only 1-2 signals, the SpO2, the oxygen levels, and the pulse. And we'll explain later on. The type 3 is called the cardiorespiratory polygraphy, and also is called limit sleep study. We have 6 signals, including ECG, heart rate, oxygen saturation, but also the airflow, thorax, and abdomen effort. So this study can be performed as outpatient or inpatient. If the study is performed as outpatient, so the patient is coming to collect the device, we'll explain how to set up the device, the patient is taken to home and return next day. The type 1 and type 2 are the most complex studies and are the gold standard for sleep disorders. So the type 2 is a portable polysomnography, which includes the brain activities, recording brain activity, electroencephalography, EOG, and electromyography. The type 2 is done as a home, and the type 1 is done as inpatient. So the patient stay overnight, and the staff, there is a video recording all the night and recording the patient behavior overnight. So usually the type 1 and type 2, so the sleep services are trying to encourage now using the portable, the type 2. So the patients can do the study at home on their own environment with their own bed, pillow, because it's really difficult to sleep with number of the electrodes on the head, chest, legs, and after usually if the patient is staying overnight, it takes 1 hour to set up everything. So, and after the setup, we should ask the patient just sleep normally, which is really difficult with all the wires and hospital environment with staff around, be recorded on video, staff in and out, just fix some electrodes. Yeah, it's really difficult, but and the end just asking the patient to sleep normally. I'm going to concentrate in type 3 and type 4, which are the most studies performed in sleep centers. The limit sleep study type 3 is used by to diagnose sleep apnea, periodic limb movement disorders, if you can have additional sensors, leg sensors, can be used to assess effectiveness of treatment, CPAP, NIV, mandibular advanced device, and also is used for research. In our service, we use 2 different devices. It's called the first one, SonaTouch Resp, is the typical sleep study, where you have the normal signals, have nasal cannula, have the belt around the chest, abdomen, finger probe, and also you can have the additional sensors, mainly on the legs. This device is a typical device, uses normal software. It's providing body position, activity, thorax abdomen effort, airflow, snoring, oxygen, SpO2, and pulse. You can see overview. The device provided plenty information about snoring, the position, the events, how everything is going overnight. You can see the pulse variability and also the oxygenation during that night. In terms of the other devices, I wouldn't say quite new, but has been released maybe 5-6 years ago, even more probably. Is used the CloudPath to manage the data. Is providing body position, actigraph, respiratory movement, SpO2, pulse, and these studies rely on peripheral arterial tone, which is so the peripheral arterial tone measures arterial pulse, volume changes in the finger as a result of vasomotion, vasoconstriction, and vasodilatation. So it's relying on different algorithms, so you don't have any flow at all. As you can see on that picture, is the device on the wrist, sensor on the finger, sensor on the chest, and is recording snoring, chest movements, and also activity. This is the template report you usually can get. Also on WatchPad, you can get sleep stages. Not the normal sleep stage, stage 1, 2, 3, and REM, and of course awake. But yeah, you can have awake, REM, light sleep, and deep sleep. At least can give us a good indication about the quality of sleep and how the sleep looks like. The limit sleep study provides plenty information, not only about oxygenation and snoring and position, but the main parameters are about AHI, which is the hypopnea index, is the average number of apnea and the hypopnea episodes you have per hour. We'll explain later on. Oxygen desaturation index is the average number of desaturation episodes occurring per hour. So we use this parameter to classify the severity of sleep apnea. If the AHI is between 0 to 5, so there isn't significant evidence of obstructive sleep apnea. If the AHI is between 5 15, is classified as mild. If it's between 15 30, you classify as moderate, and over 30 is severe obstructive sleep apnea. So in the next few slides, I'm going to explain a little bit what is going on during the sleep study. So when you open the study, go into the raw data, so how the signals look like. So that is a normal breathing. You can see on the flow, nice and steady, no oscillations on the breathing. You can see a good thorax movements and abdominal movements. And also in the second picture, you can see the patient is breathing normally in and out, no obstruction there. So the next one is called hypopnea. Hypopnea, so is a reduction on the flow, more than 30% for more than 10 seconds. Is associated with more than 3% oxygen desaturation, always. And you can see the continued respiratory effort. So you can see some oscillation on the thorax and abdomen effort, but you can't see any flat, so the muscle is still working. So there is a partial blockage on the back of the throat. And also you can see on the top the snoring, which is quite associated with obstructive sleep apnea. So the next one is obstructive apnea. So you can see a significant reduction on airflow, more than 90%, and again, must be over 10 seconds. And you can see some movements on thorax and abdomen. And you can see on the second picture, no flow in and out. So there is completely blockage on airways. So the next one is called central apnea. Is the most complex events you can see in the sleep study. So when there is a reduction more than 90% on airflow signal for more than 10 seconds, but no movements on the chest or thorax. So these events happen because the brain doesn't send proper signals to the muscles that control breathing. And these events are associated with heart failure, stroke, brain infection, kidney failure, and drugs, mainly opioids. The mixed apneas, you can see no flow, or at least reduction more than 90% on the airflow signal for more than 10 seconds. you can see a flat, no respiratory effort in the initial portion of the event, followed by the respiratory movement in the second portion. So the muscles start moving after completely no effort in the middle of the event. So the next one is the easiest device, I would say, the very old device, pulse oximetry. Probably everyone knows this device. Provides two signals, oxygenation and pulse. In our service, we use this device mainly for inpatients because it's non-invasive, it's cheap, portable, easy to set up, and also shows quite good sensitive to moderate to severe OSA. And then you can assess the effectiveness of the treatment the patients you have in the ward when they are on NIV, on oxygen therapy, on CPAP. So you can assess the oxygenation and also if there are any concerns about the carbon dioxide as well. So you can see some periods of hyperventilation, maybe you can confirm doing the blood gas in the morning. And also have significant disadvantages. So the device requires a good perfusion, have quite significant false negatives and positives, is inconsistent interpretation, there is differentiation between events types, limit signals, and artifact. But it's quite a good tool in the sleep services using this device. Many for patients have some learning disabilities, have difficulties to set up the device because it's quite easy to use and still providing plenty information. This is the template report. So despite only one or two signals, it's giving us quite good indication about oxygenation, pulse as well, median SpO2, pulse, how the pulse looks like, if you have suspect hypoventilation, hypoxemia, and then you can make clinical decisions based on these results. I just brought this slide just to, so the NICE is going to release a new guidance about the home testing devices for diagnosing obstructive sleep apnea, hypopnea syndrome. So this device probably will be available in primary care, in the pharmacy, so the patients can be tested at home on their own to rule out mainly sleep apnea. So we have one is called AcuPebble. So that device is going to stick on the throat. We have the sensor on the finger to record oxygenation and the pulse. The patient download app, download results, and the clinician will get results in after just a couple of minutes. So we are now able to go into raw data. There's no manual scoring. Is relying on the advanced algorithm. Is artificial intelligence. So as you can see, so artificial intelligence is coming for sleep as well. We have the night owl sensor on the finger, sunrise just on the chin. The device you're currently using now at the service, WatchPad 300, but also WatchPad 1, which is a single use. There are some concerns about the negative impact of some devices in our environments. But probably something you need to just monitor once the device will be available on a regular basis. I'd like to just provide some information about our new service at MTW. So our service has the aim to improve patient experience and outcomes through the provision of local diagnosis and treatment service for patients, improving access, reducing travel, and improving compliance with therapy, but also reducing pressure in the other sleep services, East Kent, Medway, Queen Victoria Hospital, and other hospitals in London. But it's not only about outpatients, but also inpatients. So I've been supporting inpatients. So usually before you open the service, the patients were waiting for 6 weeks to start the treatment, or be referred to Lane Fox. But now the patient can be tested, can start the treatment on the same day or day after, and they can be discharged earlier. So that has been releasing pressure in the wards and also the staff, and the patient can go home to their own environment earlier. The service has opened on the 5th of April 2024, so this year, offering sleep diagnostics, CPAP, and NIV on obviously hyperventilation syndrome patients and inpatients and outpatients. Our catchment area is only West Kent. We are only accepting referrals from this area. About just some information about our activity so far in the last 6 months. In terms of sleep diagnosis, already performed over 400 sleep studies. We are expecting now a business case around 500. As you can see, I mean, performing quite well and coping with the demand, but not only just performing the test, but also just reporting them. So in 1-2 weeks, the results are available to be reviewed by consultant. In terms of the treatment, between April, August, we already start or set up and the patients on CPAP. Already have done 60 reviews and 5 patients on NIV. I just brought this slide with some interesting data regarding the activity. So as you can see, the sleep studies has one of the highest average monthly growth between July 23, 2024 and August 2023, August 2024. So probably one of the reasons could be the community diagnostic center. So we have more, so the sleep studies have more space, they have more capacity. But also post-COVID, you can see the GPs are more aware about obstructive sleep apnea and sleep disorders, so they are more keen to refer the patient to the sleep centers. Thank you.